Good afternoon. I'm presenting a paper on KOCH retinal vasculitis, myself Samvedya. Retinal vasculitis is a sight-threatening inflammatory condition of the retinal vessels associated with perivascular sheathing, vitreous cells, cotton wool spots, and intraretinal hemorrhages. It commonly occurs in association with a systemic or ocular disease, but rarely may develop as an isolated disease. Etiology could be infective, non-infective, neoplastic, or idiopathic in nature. It is essential that a thorough history, review of systems, and physical examination are performed in patients. They have associated complications such as macular edema, vascular occlusion, retinal ischemia, and neovascularization, which can hamper the vision. Here we report a case of unilateral retinal vasculitis in an otherwise healthy male patient. So we have a 44-year-old male patient who presented to the OPD with sudden onset of floaters in his right eye since 5 days. His visual acuity in right eye was 618, improving to 612, and left eye was 66. Anterior segment was within normal limit in both right and left eye. On fundus examination, right eye fundus showed +2 vitreous cells, and there was superiorly severe vasculitis with surrounding hemorrhages and sheathing of retinal vessels, with inferiorly a pigmented scar and snowball opacities. Left eye fundi was within normal limit. This is the fundus picture showing superior vasculitis and inferiorly snowball opacities and a pigmented scar. Left eye fundus was within normal limit. The presence of vitritis and vascular sheathing suggested an inflammatory cause. So Mantoux test showed 12 millimeter in duration. Sputum AFB was negative. Serum ACE was 150 microgram per liter. Other blood investigations, chest X-ray and CT thorax were within normal limit. FFA showed in the right eye showed block fluorescence due to retinal hemorrhage. CNP areas were noted superiorly, temporally, and inferiorly. The foveal avascular zone was normal. The clinical findings in the diagnostic test were suggestive of retinal vasculitis secondary to query tuberculosis bar ocular sarcoidosis, and patient was started with a trial of immunosuppressants and oral steroids in the tapering dose. Additionally, a right eye laser photocoagulation was performed. The variation in the clinical presentation and lack of uniformity in diagnostic criteria makes the diagnosis difficult in case of vasculitis. We had two differentials, ocular tuberculosis and sarcoidosis. Ocular tuberculosis is an extrapulmonary manifestation of Mycobacterium tuberculosis infection. Sarcoidosis is a chronic multisystemic granulomatous disorder caused by an exaggerated cellular immune response to a variety of self or non-self antigens in a genetically predisposed individuals, resulting in non-caseating granuloma. The gold standard for the diagnosis of TB includes detection of MTB in ocular tissues or fluids, whereas in sarcoidosis, it is a tissue biopsy. Imaging techniques available are FFA, ICG, OCT, and adaptive optics, which helps in the diagnosis as well as in guiding therapy. FFA can demonstrate vascular leakage and staining and can be used to evaluate the degree of arteriitis or phlebitis. Perivascular sheathing with variable vitritis is a common finding both in sarcoidosis and tuberculosis. Candle wax drippings are associated with sarcoidosis. Choroiditis lesion with both active or healed is a common observation in TB vasculitis. The concurrent use of systemic corticosteroids and immunosuppressants were effective in this case. At 1 month follow-up, best corrected visual acuity in the patient was 6.9 in the right eye with resolving vasculitis, and this is the follow-up picture of his fundus after 6 months, which shows resolving hemorrhages and with no active lesions. Left eye fundus was within normal limit. Conclusion: extrapulmonary TB can present with no previous history of pulmonary infection. Even though it is curable, it is often missed in its extrapulmonary form. Sarcoidosis mostly affects anterior uvea, but always you should keep a differential of tuberculosis in case of vasculitis. The treatment of vasculitis is dependent on etiology. For an elusive etiology, corticosteroids along with an immunosuppressant agent may be recommended. The prognosis is variable. Early diagnosis and management can be of utmost beneficial for the patients. Thank you.
So, a few points. When you come to retinal vasculitis in a patient, unilateral, one quadrant, with just a Mantoux of 12, you don't have a PCR study, you're not sure it's tuberculosis.
Yes.
With just a serum ACE, you're not going to be sure till you don't have an HRCT chest to document your ocular sarcoidosis. A lot of unilateral single quadrant retinal vasculitis can be an idiopathic retinal vasculitis, not without any particular cause in your case. And yes, FFA is important, OCT is important, but ICG has no role.
So you mentioned retinal laser was performed in your case. What was the indication?
It was retinal hemorrhages were there.
The areas of non-perfusion.
Yes.
Okay.
That
was the reason for which they did the laser.